It's almost like it's never too early to see a heart doctor. Most people, and it depends on kind of what's going on and your risk factors and everything else. So most people traditionally will come see a heart doctor if they're having symptoms. So if, for instance, they're having some chest pain they're concerned about, or palpitations, like heart racing, that's oftentimes when people come in to see me.
You have more power over your health than what you've been told. This is the Healthy Lifestyle Solutions podcast, and I'm your host, Maya Acosta. I'm passionate about finding healthy lifestyle solutions to support optimal human health. If you're willing to go with me, together we can discover how simple lifestyle choices can help improve our quality of life and increase longevity in a big way. Let's get started. Friends, we continue our series of planted forward telehealth providers. Dr. Nicole Harkin, a board certified cardiologist, shares her thoughts on common types of heart diseases and their symptoms, how to prevent them, and why it's the leading cause of mortality in both men and women in the United States. Please join me in this conversation as we learn from Dr. Harkin about the most common risk factor of heart disease for women and what we can do to prevent it. As always, the full bio and links for each guest are located in the show notes. I hope you enjoy this episode.
Thank you so much for having me on. It's such a pleasure.
We're going to talk about those lifestyle modifications, lifestyle habits that we can take on right now before we develop any kind of heart conditions. There's so much to talk about, and I sort of made a list because I didn't want to get off topic. You're part of a series of the providers that are part of Planted Forward. And so that's the telehealth practice that you all have just created.
Yeah, absolutely. So I'm very fortunate to be a part of an amazing group of women healthcare providers. So we are physicians, registered dietitians, health coaches, and we're a collective really providing evidence-based whole person telemedicine services. And so we really work all together with our patients to really help them optimize their health. And so whether it's, nutritional guidance or doctoring or a combination of the above, we're so excited to be able to provide that to help people and really have that partnership. And telemedicine has really just opened doors for so many people to be able to get access to different providers that maybe they didn't have, more locally. Personally, I'm licensed to see patients in California, New York, and Florida. But then we have health coaches and registered dietitians who can see patients in a much larger area. And then it's just great because we all have very similar approaches in that it's a very holistic, whole person approach where we're just looking at everything. So if you see me or anyone else, we talk a lot about obviously nutrition, but also other things, exercise, thorough family histories, all of this stuff, and really give people a lot of time to kind of form that relationship, understand that person, and then help guide them in a path that's going to help their health.
Hmm. I love that you are all women because I feel that as women, we can understand each other a little bit more, especially when it comes to how we are impacted emotionally by things that happen around us, our levels of stress. And also, I guess we'll talk about how women experience symptoms related to heart disease. You also have your own practice in San Francisco.
Yeah, that's correct. So I moved from New York a little bit about a year and a half ago, and at that point decided to launch my own practice so that I could really just practice. Prevention has always been my passion, and I just really wanted to double down on that and just really focus on that exclusively, and then just really be able to practice medicine the way I wanted to practice it. The traditional medical model is, as we know, very broken. No one gets nearly enough time with their doctors as they would like, and no one's happy with it. Physicians are miserable, patients feel like they're not being heard, and so sort of just took a leap of faith and stepped out of that system, and have been able to just be really happy doing that. So I'm able to talk to my patients for an hour, really deep dive into everything that's going on. They can email me and I'll email them back with, hey, I read this study, or what do you think about this? So it's really, I mean, even though I'm doing telemedicine, which is sort of modern medicine, it's kind of also feels old school medicine too in a way, because it's back to that doctor patient relationship that really used to exist in medicine and is being lost a bit today.
I also like that all of you in the providers from Planted Forward all have had that experience with traditional forms of medicine. So you all come from that world understanding that there's something, like you said, broken in the system, and you're deciding to practice differently the way that you see is best for patients. So any chance that you'll ever practice, have a license here in Texas?
Yes, actually, Texas is on my list. So I am keeping track of all. So unfortunately, I am still bound, obviously, by the laws. And as such, we are still, as physicians, only allowed to practice in the states we're licensed in. So as there, and unfortunately, it is a lengthy and sometimes expensive process to get licensed in other states. So I'm building slowly, and I've been getting lots of requests. Actually, New Jersey, I get a lot of requests for, so I think that might be the next state I'm adding. But Texas is obviously large and a state, and so a lot of people to potentially help there as well. So that's definitely on my list as well. So please definitely email us at Planted Forward. We're keeping track. So as demand increases for certain states, then we sort of really look into those. So all of us providers are interested in making sure we help as many people as we can. And so when we hear increased demand from certain states, that's what we'll start adding those on.
So I was wondering if you can sort of explain to our listeners what is the difference between, say, a cardiologist, a heart surgeon, and not at all related to vascular surgery, but many people still think that my husband is a cardiologist, and I find that interesting. When I try to explain it, what a vascular surgeon does, I try to think of, say, a plumber who kind of goes in and cleans the pipes. And he always emphasizes that he'll do the carotid arteries, he'll clean out the leg blockages, but when it comes to the brain he does not do that, and when it comes to the heart he also does not specialize in that. So what exactly does a cardiologist do?
Yeah, so in its most basic sense, a cardiologist is a heart doctor. And as you mentioned, that can mean lots of different things. So we can get into the different types of heart disease that we tend to see. But a cardiologist is someone who has done, after medical school, they've trained for 3 years in internal medicine, sort of just understanding kind of whole body medicine, and then specializes in specifically the heart. So then they'll go on to do 3 years of a cardiology fellowship specifically. A cardiologist tends to, and then from there you can subspecialize as well. So I chose to kind of really subspecialize in preventive cardiology, but there's doctors that specialize in the plumbing of the heart, as you mentioned. So those are interventional cardiologists. They put stents in and things like that. And then there's electrophysiologists, who are types of heart doctors that help with arrhythmias, and can do procedures if someone needs a pacemaker, for instance, or if someone needs what's called an ablation, which is a specific procedure that can help to treat rhythm issues, like atrial fibrillation is probably something that your readers have heard about. There are specialists in cardiology who deal with congenital heart disease. So, heart disease that people are born with. And then there is congestive heart failure, which is the other really common thing that we see, and that's when the heart pump function is not working as well as it should. And so those doctors are really key in kind of helping to optimize their medications and treatments to help the heart improve, if possible, and at the very least, their symptoms. So those are the different types of heart doctors. And in general, what cardiologists do is they treat any number of those different heart conditions, typically using medications and hopefully with also lifestyle changes and things like that. Some of them do procedures, as I mentioned. So there are some procedures, but that differs from, say, a surgeon who is opening up the chest and performing an actual surgery. So cardiologists who are interventional cardiologists can fix valves and put stents in and things like that, but it's all performed percutaneously, which means through kind of an artery in the leg or the arm or something like that.
What was it like when you were in the regular system? Because I'm assuming that you had very limited time with your patients.
Yeah, so a general cardiologist, which is someone who kind of isn't subspecialized into one of those areas that I mentioned, but does sort of general cardiology. Oftentimes, they have a clinic, whether it's at a hospital or a private practice, where they have a fairly large panel of patients that they're seeing. Most cardiologists will start their mornings rounding in the hospital if they have any patients that are admitted to the hospital. They see them there and help coordinate treatment plans, and then go to the office and have a full day of patients. Most cardiologists also are reading different heart tests. So there's heart testing that we can do, like echocardiograms. Those are sonograms of the heart, and there we can look at the pump function of the heart. So I'm also board certified and able to read and interpret those tests. We also supervise and interpret stress tests, which are there's a couple different forms, but in its most basic sense is where you're looking at you're looking for blockages essentially in the heart, that might be causing chest pain or shortness of breath. And so we supervise those tests often on a treadmill, and then interpret the EKGs and the imaging for that as well. So most cardiologists will supervise and interpret and read those tests throughout the day. In between patients, many are seeing many patients a day, charting, and then call in the hospital as well. So most cardiologists will take significant amounts of call, in which they're responsible for going into the hospital overnight for emergencies.
So I was wondering if you can sort of give our listeners a little bit of a general view of the different types of heart disease. And then if you could tell us, at what point do we know that we need to see a cardiologist? At what point do we realize that there's something wrong with our heart?
That's a great question. So, in general, when we're talking about sort of heart disease, typically what we're discussing is the blockages in the arteries of the heart. So that's typically what people think about when they think about heart disease. And as you mentioned, heart disease is the number one killer of both men and women here in the States, but also globally. And it's also a very big cause of morbidity or disability. So it's a huge topic, and something that's just really important to talk about. And I love that you're here doing a whole series on Heart Health Month. So the blockages of the arteries is what is something that is a very large bulk of heart disease. But as we mentioned, there's all different kinds of heart disease, some of which has similar risk factors, others or which are completely unrelated. So congestive heart failure is another big one, which is where the pump function of the heart muscle isn't working as well. And that can be due to heart attacks over time, can also be due to many other causes, alcohol use, all kinds of different things can cause that. And so that's another very large area of heart disease. And then rhythm issues, like we mentioned, like atrial fibrillation, that's part of kind of heart disease, congenital heart disease, which we mentioned. So all these different groups of heart disease kind of go under that big umbrella. And then to kind of get to your second question, um, it's almost like it's never too early to see a heart doctor. Most people, and it depends on kind of what's going on and your risk factors and everything else. So most people traditionally will come see a heart doctor if they're having symptoms. So if, for instance, they're having some chest pain they're concerned about, or palpitations, like heart racing, that's oftentimes when people come in to see me. So that's usually when people start to get plugged in. In my current practice, more and more, I typically am seeing sort of two different groups of patients. And it gets into the different types of prevention there is. So there's something called primary prevention, which are patients, which is when you're trying to prevent heart disease from establishing. So I get a lot of patients who have strong family histories of heart disease, or who have very high cholesterol or any number of risk factors for heart disease. And so they want to come in and see me and really figure out how to best optimize that and really make sure they're minimizing all of these risk factors so that they can hopefully prevent heart disease in the first place. And then I have a whole another group of patients who have heart disease. They've either had a heart attack or a stent or a positive stress test, and they want to really work on making sure that they don't have any further events. And that's called secondary prevention. And so we see those patients as well. So there's all kinds of reasons to see, a heart doctor. The best place to start typically, if you're concerned, would be to talk to your primary care doctor and say, hey, my heart health, because of my dad or this, that, or the other, I'm concerned about it. Would you recommend that I see a heart doctor at this point? Many primary care doctors, can manage some of that stuff, and then others, recommend that you really get a consultation with someone.
Okay, that's good to know. When you talk about the primary prevention, I'm thinking of people who have asked us, believe it or not, is there any way that I can find out whether I already have blockages? So part of that question is you having mentioned, and we hear it from Dr. Greger, but you also have said that heart disease, or at least atherosclerosis, starts at a very young age from childhood. So most of us do have probably some sort of blockage. So if we're interested in knowing whether we are at risk, whether we have blockages in our arteries, is there something that can be done to test for that?
Yeah. So for patients who aren't having any symptoms at all, meaning they're asymptomatic, but are interested in sort of getting an understanding of what their heart health kind of looks like right now, there's some non-invasive ways that we can assess that. And so typically we will look at something called a coronary artery calcium score. And a corollary of that is another type of CAT scan that uses dye, but most commonly it's the coronary artery calcium score, CAC for short. So you might hear it referred to as that. Basically, what that is it's a very specialized CAT scan that's looking just at the arteries in your heart, and specifically, it's quantifying the amount of calcium that is in the arteries of your heart. It's important to note that when a plaque has been calcified, that actually means it's an old plaque, not a new plaque. So how plaques sort of develop is you get cholesterol, it's in your bloodstream, it kind of gets through the walls of the artery, deposits, builds up over time, and then it starts to evolve and eventually gets calcified over time. So when you're doing these coronary artery calcium scores, you're actually kind of identifying older plaque. And then you can use that, so it quantifies it. It will give you a number of, and then it will also give you kind of an idea of your percentile, so where you fall in based on other individuals that you're with your same age and gender. And that can be really helpful to sort of get a sense of, what's going on right now. Keeping in mind that caveat that I mentioned is that it doesn't identify that early soft plaque. So it can be useful, for instance, in say a younger person who has elevated cholesterol. We've really worked on a lot of dietary changes. We can't seem to get that cholesterol quite down, and we get the coronary artery calcium score, and it's very elevated. So that can kind of help us make that decision. Okay, this cholesterol is very important at this point. We're already seeing deposition. We need to do something about it and really talk more seriously about medications, for instance. So it can be very helpful with treatment decisions and helping people sort of get a sense of where they're at. And then the flip side of that is, someone who you're sort of on the borderline, but they're kind of getting their numbers down, and you get the coronary calcium score and it's 0. So that's a little bit reassuring. Okay, so far things look pretty good. We still want to get these numbers down, but we've got some time to work on this together.
Yes, thank you. Also, more specifically, speaking about women, I had mentioned previously that I found it interesting that conditions that women may develop during a pregnancy, for example, could be indicators that there's something going on and that one should take into consideration these risk factors. So, for example, preeclampsia. And also, I've heard that symptoms can be a little different for women, while men, for example, may experience a sharp pain in the heart, in the chest area. What are some of the common symptoms that women may experience that can be subtle when there's something going on with the heart?
Yeah, so I think it's really important that we discuss women and heart disease specifically, because as you mentioned, it can affect us very differently, and there are different risk factors. So the most common risk factors for women for heart disease are the same as they are for men. So things like diabetes, high cholesterol, high blood pressure, being above our ideal body weight, sedentary lifestyle, family history, smoking, and obviously nutrition. So the big risk factors are common, but there are certainly some risk factors that are unique to women. And so the hormonal and pregnancy related ones are probably some of the most important ones. And so there is a relationship between some pregnancy complications, specifically definitely preeclampsia, but also gestational diabetes, gestational hypertension, and then actually having a small for gestational age weight baby. So these pregnancy complications, quote unquote, are it's really important to recognize that they are associated with an increased risk of heart disease later in life. And so whether it's unfortunately still very poorly understood. Some of it may be that it is sort of unmasking a woman's risk for heart disease because of XYZ risk factors. But there also is increasing evidence that, in and of itself, preeclampsia can cause vascular changes that then makes it more likely that a woman will develop heart disease later in life. Regardless, what we do know is it does matter. And it's important for, I think, women to know because, one, it's under recognized in general, as you said, in the general population, but even within kind of the medical community as well. And so your doctor should be, you should definitely, if you've had a pregnancy complication like that and you're now sort of in your middle aged and kind of starting to think more seriously about heart disease prevention and things like that, make sure your doctor knows that, because that is something that should be taken into account when we're sort of assessing cardiovascular risk. And so it's kind of a risk enhancing feature, meaning that you want to make sure that that obviously you can't change the preeclampsia you had 20 years ago, but it does mean that you want to sort of do everything you can from a lifestyle perspective to try to lower your risk in general. And then also, make sure that cholesterol is really well controlled, make sure you're not smoking, make sure the diabetes is really well controlled, those sort of things. So it's stuff that all kind of goes into our comprehensive understanding of your overall cardiovascular risk. Um, and then just kind of touching on that second question you had about women and how their symptoms. So the most common presenting symptom of a heart attack for a woman is actually chest pain, but it may be experienced differently than a man. So it can be that classic elephant sitting on my chest, pressure-like sensation, or it can be a little bit more subtle. It can feel more like an upset stomach. Sometimes it can be felt sort of more in the neck or the upper abdomen. Sometimes in the shoulder region. Also, we are more likely to have sort of atypical symptoms, quote unquote, things like just sort of really bad fatigue, really nauseous, just kind of general feeling of very unwell or anxious. So there are other symptoms that we can have in conjunction with this chest pain or in isolation. And women are more likely to present late, meaning we don't really believe we're having a heart attack. And so we come into the emergency room much later than we should. And we tend to have worse outcomes, both because we're presenting later, as well as because historically we've been prescribed less medication and have received less timely treatment. So for all these reasons, it's just important for us not to be scared, but just to be aware and to be our own advocates, and to really, we're oftentimes so worried about everybody else's health, the kids, our spouses, everybody, that we kind of forget to take care of ourselves and make sure we're going to our doctor's appointments and we're on top of these things and things and things like that. So keep looking after yourself. Your health is just as important as everybody else's in the family. And then also, if you feel like something might be wrong, get it checked out, be an advocate. Don't just blow it off.
Now, I did mention before we move on to looking at numbers and then, treatment and lifestyle, I was wondering if you can speak a little bit about what I've been hearing about lately in the news about broken heart syndrome and how those numbers have gone up since we've been experiencing this pandemic. What have you seen on your end? And can you explain to our listeners a little bit about what that means?
Yeah, so broken heart syndrome, for those of you who haven't heard of what it essentially is a temporary congestive heart failure. So essentially what happens is that typically in response to a really surprising, devastating event or stressful event, that someone will have some chest pain. It presents very similarly as a heart attack. So oftentimes the EKG and the sonogram will look like you're having a heart attack. And then we go in to look at the arteries of the heart, and there's no heart attack. There's no plaque that's broken, that's ruptured. Everything looks fine. The arteries look fine. But for whatever reason, the pump function of the muscle is depressed, meaning your heart is not pumping as well as it should, and it has a very specific kind of pattern. Luckily, it is temporary. Over weeks to months, it typically normalizes, and sometimes with the help of medications, other times not, and does not seem to sort of predispose you to having heart disease later down the line. But it can be quite serious. It can definitely require hospitalizations, and medications to help support the cardiovascular system temporarily. So people can be quite sick. And so it's just important to recognize. And again, we typically used to see it in a lot in relation to just a really shocking, stressful, surprising event. But it can happen for any number of reasons. And so, over the course of COVID and all of these different, stresses at an all-time high, and things like that. And so it's not totally altogether surprising that we're seeing this. And then that just needs to be sort of that's a separate entity than the other COVID related heart disease that we've been hearing about, which is the myocarditis, which is the actual inflammation in response to a viral infection, which can cause the heart to not pump as well. And that can be very, very, very serious. And we've always seen that with different viruses, but we're certainly seeing it with COVID as well.
So now, if we can look at numbers, because I've heard you talk about cholesterol, more specifically, how we can't necessarily focus too much on the total cholesterol number. What is important for us to look at?
So it's important to look at the overall picture. Cholesterol is one of the most important risk factors for heart disease. But it's definitely not the only. And it is necessary to develop heart disease. So cholesterol is what creates that plaque. So elevated levels of cholesterol within the bloodstream, or more accurately, the lipoproteins that carry the cholesterol in the bloodstream, is causative of heart disease. And so that's a big one that we focus on. We also worry about, as you mentioned, different things that can cause the endothelium, which is the lining of the blood vessel, to be weaker, and so things, or inflamed. And so chronic inflammation is a big one. Glucose control, smoking, which causes inflammation. All these things can also increase our risk, hypertension, of heart disease. But definitely cholesterol is a big one, and one that I tend to focus on a lot in my practice. With regards to kind of what numbers to look for, when you're getting that standard lipid panel from your physician, what it will show is your total cholesterol, which is all of the cholesterol contained with all of the lipoproteins within your bloodstream. And then it will give you the LDL cholesterol, the HDL cholesterol, and the triglycerides. So the LDL cholesterol and the HDL cholesterol, known to many people as the bad cholesterol and the good cholesterol, those are, again, that's the amount of cholesterol that's contained within those lipoproteins. So most physicians focus pretty exclusively on, at this point, at least as your first priority, the LDL cholesterol. We don't focus as much on the total cholesterol simply because that is also taking into account your HDL cholesterol. Now, HDL cholesterol is very complicated, but in its most simplistic sense, it is not. It's not quite as protective as we once thought. At least as it's reflected in that HDL number. But it's certainly the LDL cholesterol that is one of the more atherogenic, meaning causing plaque buildup. And so that's why we tend to focus on that. The HDL cholesterol epidemiologically is associated, when it's elevated, is actually associated with lower risk of heart disease. We're finding out more and more how complicated it is, and that it matters more about its ability to perform its function rather than that HDL cholesterol number. But for that reason, the total cholesterol isn't as informative, because you can have kind of an elevated HDL cholesterol, and that's maybe not the worst thing in the world. If it gets too high, it turns out that's probably not so good. But the more elevated numbers that we sometimes see is probably okay. So for all those reasons, we really focus on the LDL cholesterol. And for that, we like to see that, definitely ideally below 100 milligrams per deciliter. And that's kind of for average risk individual. In someone who has multiple risk factors for heart disease, or established heart disease, or has diabetes, we really like to see that even lower. So definitely for my patients with heart disease, it should be below 70 milligrams per deciliter. I like to push it down even lower if possible. So those are sort of the numbers that we look at. Again, with the HDL cholesterol, we can talk about different things that can potentially raise it. But honestly, we've yet to show that by raising your HDL cholesterol in a trial that we can prevent heart disease. So as of now, it's not something that we're as focused on. And then the triglycerides are sort of your secondary target, and we can get into those if we have time. But really, that LDL cholesterol is the most focused, simply because we've shown study after study after study that either individuals who naturally have low LDL cholesterol, or who push it down with lifestyle and or medications, have lower risk of heart disease.
Just a quick question about that. Well, actually, two about that. Can stress contribute to cholesterol, high cholesterol, and diet? So, this is another interesting thing. So, we've had people come to us and say, well, I've gone fully plant based and my numbers are not changing. My cholesterol is still pretty high. We often say that if you're eating a heavily processed vegan diet, then you just have the standard American diet veganized pretty much, because processed foods still contain all the high levels of oil, sugars, and salts that we should not be consuming. What do you think about that?
So, stress does not typically robustly increase LDL cholesterol. However, we do know that chronic stress, as well as acute stress, can adversely affect our risk for heart disease. So, it is very important. And we've got pretty good data at this point that stress reduction techniques like meditation and things like that can moderately lower blood pressure, and other risk factors for heart disease. And so certainly stress is something that I focus on a lot in my practice with my patients. Not so much to lower their cholesterol, but to lower their overall risk of heart disease. Um, and then in terms of diet, yes. So there's lots of different reasons that our cholesterol can be elevated, and so diet is probably one of the most impactful ways that we can lower our cholesterol. But as you correctly pointed out, we really need to make sure that we're focusing on a whole food, plant-based diet as opposed to a vegan diet if we're interested in lowering our cholesterol. And that's different in that, again, you're focusing on kind of whole foods that are plants as much as possible, as opposed to processed and packaged foods. And why that we see that distinction is when it comes to cholesterol, for instance, is because in order to lower our cholesterol, sort of the two things that we really need to focus on is one, reducing our intake of saturated fats. So saturated fats are what raises our blood level of cholesterol. And those are predominantly found in animal foods. So we see them in red meat and other meats, definitely processed meats, and then dairy, butter, cheeses, yogurts, things like that. And then we do find it in coconut oil and in palm oil. And so that's how, as a vegan, if you're eating a lot of processed foods, those typically have one or both of those oils in them. That's how we can really raise our cholesterol. And then what we want to focus on eating more of is fiber, specifically soluble fiber. And that's what helps us to really lower our cholesterol. And those are found mostly in unprocessed whole plant foods. So getting lots and lots and lots of fiber is a way that we can really help lower our cholesterol. So certainly one of the first things I talk to my patients about if they're not eating very many animal products, but they don't understand why their cholesterol is going down is, okay, tell me what specifically you are eating, and we try to find ways that we can make it be a little bit less processed and get more fiber in their diet. And then secondly, definitely genetics are important. And there are definitely many different genetic causes of elevated cholesterol that respond differently to changes in diet. And some patients, despite eating a very whole food, plant-based, no oil, no sugar, no salt, still don't see their cholesterols kind of getting down where they want them to be. And unfortunately, genetics you can't always quote unquote beat your genetics. Now, that's not to say that the eating a healthy lifestyle isn't still very important, because as we mentioned, cholesterol isn't everything, right? It is important that you're eating that way to lower your blood pressure, to lower your levels of inflammation. All that stuff is still very, very important. It just might mean that in order to get our cholesterol to a safe level, you might need to reach for something else, and sometimes that's a medication, and that's okay. That's not a failure, right? That is the beauty of being able to have all these different tools at our disposal to optimize our heart health.
I've also heard you say that supplementing with something like a plant sterol can be just as effective as a statin. So wonder if you want to talk about that. And I've also heard you mention the portfolio diet, which was new to me, but it's basically all the right foods to help reduce cholesterol. Is that right?
Yeah, so that's actually what I was referring to with the plant stanol sterols. That's part of the portfolio diet. So we do have some studies to show that consuming a portfolio diet, which is essentially a whole food plant-based diet, but really focuses on getting certain amounts of plant protein, specifically soy was used in the studies, soluble fiber, getting around 20 grams of soluble fiber a day, and then consuming a handful of nuts a day, and then the plant stanol sterols, which are basically for your listeners, what those are is they're basically the plant form of cholesterol, and they're found in all plants in pretty small quantities. It's actually difficult to get larger quantities just because there's so small quantities in the foods. So in the studies they actually did, that was the one supplements that they used really, was to get about 2 grams of plant stanols and sterols in. And so with following that diet in the context of a low saturated fat intake, they compared that to that diet, just a low saturated fat, but not specifically trying to, increase your plant intake, and then a statin group plus low saturated fat. And they found that the portfolio diet was equivalent to this low dose statin. So certainly in the context of a whole food plant-based diet, that's one way that someone who's already eating a specific way, that, kind of really focusing on those specific foods can kind of help you tweak your diet a little bit to potentially lower your cholesterol even further.
Okay, this is great. There's so much more that I could ask about. Well, I guess as we're beginning to wrap up, maybe if you'd like to give us additional tips related to lifestyle modifications, things that we can do to reduce our risk, or if we've already had an event, to continue to kind of take care of our hearts.
Yeah, so definitely looking at your diet, as we sort of already touched on, that's one of my top areas where I really work with my patients on trying to fine tune their diet and troubleshoot together and make sure we're kind of, you know, on average, eating as healthfully as we can to promote heart health. And then the other levers, which I barely touched on or didn't touch on at all, that are really important is exercise. So that's another really big area with a lot of robust research to show that definitely getting at least 150 minutes of moderate intensity exercise per week is what we need to achieve optimal heart health. We continue to see benefits all the way up to 300 minutes of moderate intensity exercise per week. So if you have the time, that's great. And then beyond that, we don't see much additional benefit and maybe a signal of harm. We also have research to show if you have no time to exercise, but you just do a little bit of something, that is actually better than nothing. And that we have good data to show that as well. So exercise is important. If you can get in resistance training as well, meaning some sort of strength training, Pilates, yoga, something that's really focusing on working your muscles, that's really good as well. And so we recommend 2 sessions of that per week as well if you can. So that's exercise in a very quick nutshell. And then the other levers that we talked about, sort of stress reduction, that is really, really huge and a really big area for many of my patients who their blood pressure is just a little higher than it needs to be, or it's really labile, really working on breathing techniques and meditation and different ways to find mindfulness. And then sleep is another big one. So inadequate, sort of both quantity as well as quality of sleep. I diagnose obstructive sleep apnea all the time. That is a big risk factor for heart disease. So that's a big one to kind of be mindful of and pay attention to as well. And then the community and the connections and things like that. And just finding people that bring you joy. That's another kind of lever. And so all those things kind of go into heart health, but also just health in general.
And you lightly touched on blood pressure, which we didn't focus a lot on, but that's also with certain foods. You can also lower your blood pressure. I know one particular person who refuses to take her medication because she doesn't like how she feels. And unfortunately, then that's when we're talking about needing physicians or cardiologists who can believe in the power of foods to encourage the individual to take your medication, but we can slowly take you off as long as you're making these changes with lifestyle, but also nutrition, right?
Yeah, and I think for a lot of patients, it's about kind of feeling like you're being heard and that it's a team, right? And I think that that's sort of, I mean, again, it goes back to kind of practicing that old school medicine where we're a team and we're going to work on this together. And so I think that certainly lots of people can manage their blood pressure with, a plant-based DASH style diet, low in sodium, high in potassium foods. Those are great ways to lower blood pressure, and that works for many people. It doesn't work for everyone, though. And so, being able to have that conversation and let's work on these changes. But if it's really dangerously high, let's try a little low dose of maybe this one. Okay, that didn't work. Let's try a different one. And so many people who either medications they feel like they don't work for them or they don't want to take them. It's really just simply because they haven't felt heard and felt like they're part of the team and making that kind of decision together. And I think once you just make it very clear that you're in charge, it's your body, I'm just here to help guide you, and if you don't like this, we'll switch it to something else or whatever. That is just so powerful, and it goes such a long way to really feeling like people are in charge of their health, and they often will make different decisions based on it sort of discussed in that way.
Right. And you've said that patients do better when they're, like you said, involved in their own treatment plan, but also just when you put together an individualized plan for them, they do a lot better. Probably because, like you said, they feel heard. This has been wonderful. There's so much more that I could ask. But Dr. Harkin, if people are interested in learning more about you, your work, what is the best way that they can contact you?
All of us are at plantedforward.com. So you can just go to our website, learn more about us there, book directly with any of us on that website. So that's probably one of the easiest ways to become my patient. You can, book your appointments through that. And then just for general knowledge and things like that, I'm most active on Instagram. So Nicole Harkin, MD. You can follow me there. I post different tips and what I'm eating and all kinds of stuff. And I love being and seeing faces around there. So
Yay. Well, thank you so much. I appreciate you again. I know that you've been busy this month, really encouraging people to put all these lifestyle changes in place so that they can prevent or reduce the risk for heart disease. So I thank you for all the work that you're doing and for making time today to speak to our listeners.
it was my pleasure. I really, really enjoyed it. Thank you so much for having me on.
You've been listening to the Healthy Lifestyle Solutions podcast with your host, Maya Acosta. If you've enjoyed this podcast, do us a favor and share with one friend who can benefit from this episode. Feel free to leave us an honest review on Apple Podcasts. That helps us to spread our message. You can also head on over to podinbox.com/HLS to leave me a voicemail. Don't forget to subscribe. And as always, thank you for listening.